Our next session is the Chennai Oration, and for that I'd like to call upon stage Professor Darius Mirza, who's the orator, Dr. Naganath Babu, Dr. Anadi Acharya, Sadiq Sikora, Dr. VP Bhalla, Dr. Pradeep Rebala, and Dr. Rajneesh Singh. Please. I would also request Dr. Rajneesh Singh to come on the dais.
Put a pen drive. Pen drive. Can somebody help me, please? You guys are really slow. Pen drive. Okay. Yeah. Good morning, ladies and gentlemen. This is it's time for the Chennai Oration. The Chennai Oration was started in 1995. Professor Ahmed Ali, who organized the 5th annual conference of IASG, had sponsored, provided a corpus. The department of that time had provided a corpus to start what is now called the Chennai Oration. It is by an invited luminary in the field of GI surgery from an international audience. From 2012 onwards, we had other orations competing for it, so Chennai Oration is now held in an alternate year. And as I have just put the list forth, the list of speakers for the Chennai Oration have been really kind of legends in their own fields. I'm sorry, I think I've missed out the 21. So from Steve Wexner, David Jain, William Chen, Doug Goma, Dr. Yang Kim. So these are all luminaries in this field. So it gives me great pleasure to invite Professor Darius Mirza from Birmingham, UK, to deliver this oration. I would request Dr. Sanjay Mandal to provide the introduction of the speaker, please.
Thank you. It's my privilege to introduce Professor Darius Mirza. He is the honorary professor of HPB and transplant surgery at University of Birmingham and consultant HPB and transplant surgeon at Queen Elizabeth Hospital and Birmingham Children's Hospital, UK. He was appointed consultant transplant surgeon and HPB surgeon in 1996 after training in Mumbai, Vienna, and Birmingham. His areas of interest include surgical innovation, liver splitting, segment grafts, novel perfusion techniques, use of marginal donors, and pediatric transplantation, both all liver, bowel, and multivessel. In the field of HPB surgery, his interests lie in major liver and pancreatic resections for cancer, bile duct strictures, complex pediatric HPB surgeries, including portosystemic shunt surgery. He has over 425 publications and has raised grants in excess of £12 million, has been involved as a principal investigator in 12 multi-center national and international clinical trials, and is committed to developing transplant and HPV services worldwide, with over 900 fellows transitioning through Birmingham since 1991. Of these, 125 are from India. Over a 26-year consultant career, he was the clinical lead for liver surgery in Birmingham, lead cancer clinician for HPB surgery in Birmingham, chair for British Liver Transplant Group, chair of the Bowel Advisory Group, chair for Midlands HPB Cancer Supra Network, secretary of the European Liver International Transplant Association. He holds several international awards, including recognition from the Australian College of Surgeons, the Intestinal Transplant Surgeon, the European Intestinal and Liver Transplant Association, the Australian Association of Surgeons, the Mumbai Zonal Transplant Committee, and a Pakistan President National Award. In 2017-18, he spent 18 months on a sabbatical in Mumbai to set up a liver transplant program in the then newly opened 500-bedded Apollo Hospital to establish charity to help fund transplantation. During the pandemic, he ensured transplant activity was maintained and was involved with delivering specialist HPV surgery for NHS patients at a smaller private hospital. In September 2022, he was one of the 6 clinicians awarded a Lifetime Achievement Award by the British Transplant Society on occasion of the 50th anniversary. With this, I'd like to welcome Professor Mirza to come and give his talk. Sir.
Thank you very much. While the panel takes their seats, I'd like to thank everybody, particularly the organizers, Dr. Bhalla and the team, for the very kind and prestigious invitation. It's quite a daunting task, having just seen the Roll of Honor, because that wasn't shared with me before this meeting. So I've got the best part of 35 minutes to spend some time talk to you about what started off as a very small subgroup or sub-activity of abdominal surgery, which has then evolved into something that we all know is the big beast of HPV surgery and transplantation. So we're a big hospital. Even by NHS standards, we're massive now. So we're 5 hospital sites. We started off as a very small unit on the 3rd floor of one of the smaller sand-colored buildings there in the middle. And that was a 300-bedded specialist hospital called the QE, which did not have an emergency take and would just do mainly complex secondary and tertiary work. It has grown into a huge program that has 500+ transplant procedures a year. We cover both thoracic and abdominal organs, and there's lots of other additional facets to the big institution that are not necessarily always working out to our advantage. People know the early story of liver transplantation. I think there's a few important things that people don't know, that it took a good 10-15 years to get it going, and that the early results were hugely disappointing, by current standards. 1 in 4 patients survived. The early Cambridge data had less than 25% survival. And one of the quotes from one of my colleagues, James Newberger, was that there was no statistically difference in survival between donors and recipients for the first 5 years of the Cambridge program. So I think if you put that into perspective, you would not be able to start transplantation with those kinds of results in 2021, 2022. I was a second-year medical student when the New England Journal paper came out, authored by Tom Starzl. There were 2 issues. They follow one after the other. And he wrote about moving transplantation from an experimental procedure in 1983 to an established procedure. And that, along with the arrival of cyclosporin, allowed things to develop. So how did we develop? So we started off with 2 fantastic young men who are not so young now, Paul McMaster, Alvin Elias. They moved from Cambridge and from the Royal Free to the Midlands, and it took them a best part of a year to start. And we started exactly 40 years ago in January. It took a year and a half to start. The first year we did 4 transplants, and it's interesting, the second patient was a patient who had HCC well outside any conventional criteria that you would accept just now. That patient survived 21 years. We were also probably the first amongst teams, and the last half an hour's discussion says it all, of putting together a multidisciplinary team in the mid-1980s, where it wasn't seen as a surgical procedure, it was seen as a team procedure with anesthetists, with intensivists, with hepatologists, and we can't exactly date that picture, but just from the consultants and the trainees that you can see who all became subsequent consultants, we think it was 1987. So this was MDT practice long before MDTs became routine. And this is another paper that I think is very important. So this was the first blow-by-blow account of the first 45 transplants in Birmingham. And this I think this makes spectacular reading. It shows you that almost every patient had a problem. Only half the patients survived. Lots of reoperations. Acute rejection was very common. We had lots of problems in patients who bled. And if you got an opportunistic fungal infection, you did not survive that. So from 70s to the 80s, this is a period of almost 15 years, the results have improved from 25% to 50+%. Again, something that you could not get away with in this day and age. So most of the 90s was spent with learning a lot. Prior to this, hardly any histology was done. And we introduced something, this is before my time in Birmingham, we introduced standard histology, both time 0 biopsies, routine day 7 biopsies, all to learn about what happens to these grafts. There's almost nothing in the literature before that. And for that, a huge amount of credit has to go to a young Stephen Hoopscher, a young Desley Neal, and Professor David Adams. This picture's taken in Banff, where they meet still every year in Canada to decide what's new in liver histology. Some key messages there: rejection was common, can happen without deranged chemistry. Mild rejection or moderate asymptomatic rejection does not need treatment. Steroid withdrawal is safe and good for patients, and kids don't need immunosuppression. It also became clear that children were going to be quite an important part of any transplant unit. So within the first 10 transplants, I'd already done the first kid, but the pediatric program was really slow to start till the appointment of Professor Kelly. Again, showing you the importance of multidisciplinary working with a consultant, pediatric hepatologist. And with her appointment and with the setting up of a separate unit at the Children's Hospital, the growth in the pediatric program occurred quite rapidly. And we're now at a figure of between 35 and 40 pediatric transplants a year, working with 2 teams, a Children's Hospital team and an adult team, with some of us working at both places. It also became very clear that you could not depend on the whole organ to be able to provide transplantation for children. And a lot of the early work in the 1980s was about how to find matching grafts for these children. And through the 80s and the 90s, a lot of technical innovation occurred. So the reduced grafts were the first grafts that happened. Obviously, there was a wastage of the right lobe there. We then introduced split liver transplantation in the early 1990s. We then systemized it, became a normal intention to split procedure for all our good donors. And then that same practice, so by splitting, I mean a right lobe going to an adult and a left lobe going to a child, we then were able to convince our colleagues around the country to adopt this same policy on a national level. So any donor nationally that satisfies those criteria, you're young, you're reasonably stable, you've been on the ICU for a short period of time, that liver automatically gets offered for splitting before it gets allocated into an adult. This way you're making best use of the best quality donor livers that are there. And with splitting and reduction, we were able to change completely the dynamics of how children received livers. For the left lobes, there was no difference in outcomes between whole livers and the split grafts. For the right lobes, there was a bit of a learning curve. And that learning curve has been repeated for all other technical variant type transplantation. We're looking at transplant outcomes now well in excess of 90%, 95%. These are audited results, these are national results, these are results that we have to return back and are provided back to us in terms of outcomes. And as a consequence of these good outcomes, we've now stretched the limit for intention to splitting. And this is again only dependent on an IT change at NHS Blood and Transplant before we can start to implement these newer criteria. So the technical variant graft took over in the late 80s and the early 90s the place of the whole graft. And at the same time, that progression was such that almost all the children now in Europe, in countries that have a good splitting program, will be serviced by liver splitting, and in countries that don't have a good splitting program, will have to resort to living-related liver transplantation in that setting. We were able to then adapt some of the techniques that we use with liver transplantation for multivisceral transplantation, because these also were a highly vulnerable group of recipients, very small, no abdomens, no ascites, big spleens, big livers, and finding space in these very tight, compact, contracted abdomens with horribly placed stomas was very difficult. So we used reduction. And again, probably still the only team in the world that are using liver reduction and or bowel reduction to try and help multivisceral transplantation. I'm going to shift a little bit to the challenges we're currently facing with our organ donation pool. So our current organ donation pool is rising, it's increasing. It's about 70% DBD and 30% DCD. The utilization in the DCD population is low, and it has dropped further over COVID. And I don't have time to explain why we've decided to focus mainly on the DBD grafts. With the DBD grafts, your early concern is always of early graft dysfunction. With the DCD grafts, your concerns usually relate to later problems with the biliary tree. So we introduced DCD transplantation about 18, 19 years ago. And soon it grew to between 30 to 35% of our transplants. Our criteria were very rigid initially, and then within a year or two, they became extended. So now we are taking on DCD grafts in donors in excess of 70 years of age, provided you keep ischemia times as short as possible. These grafts do come with some baggage. The baggage is that of biliary complications. But in some work done looking at a nice propensity-matched study, you can see that the outcomes are more or less the same with the price of some biliary problems. So the biliary problems still remain with the DCD grafts. How do you reduce that? There's lots of measures. The simple things like keeping pressure perfusion in donors, keeping the early flush in the donor of a low viscosity, to keep the warm ischemia time short, are all pretty standard. But we've had to resort to the use of novel technology to try and get improvements. And I'll spend some time about that later on. On the DBD side of things, because of the pressures of our waiting list, we've always had an interest in pushing the use of what at each time period is considered an extended criteria donor. We're now at a stage where, 25, 30 years after a couple of key publications, that 80 to 90% of donors today would be considered extended criteria as of 25 years ago. So this was a questionnaire that we put out on 30 livers that we had used. We never told the other European centers we'd use them. We sent them out as hypothetical things. And you could see that most people were not willing to accept this. This is the early to mid 90s. But the centers that had confidence doing more transplants with bigger waiting list pressures were willing to be more adventurous, just showing there's a huge subjective component to use of these organs. How do you convert subjectivity into objectivity? Because that's so important. Us surgeons are hugely subjective people. It's quite difficult for us to look at things objectively. So we looked at all the criteria that were considered marginal. Donor weight, hemodynamic instability, trauma as a cause, paracetamol overdose as a cause, etc., etc. And the only two factors that really came up as being significant were donor age and significant hepatic steatosis. And if you kept your ischemia times short, you could change the way the ROC curve. So the way we functioned for the next 10, 12, 15 years was to keep ischemia times very short for the older donors and the steatotic livers. We still were not using the severely steatotic livers because they have a problem with significant early dysfunction. As you can see, a large number of livers that are turned down are turned down largely because of fat. Again, assessing fat is difficult. Surgeons are highly subjective in what they call a steatotic liver. The gold standard there is pathology. The problem is in the middle of the night, you don't get a gold standard pathologist to be able to tell you. And if you depended on less than ideal pathology, you'll end up not using what might be perfectly usable organs. And that's where the last 10 years of the machine perfusion technology revolution has helped. It's still not yet provided all the solutions, but it's allowed us to assess these livers far better. So I'll spend the next 5 or 10 minutes just talking about the last 10 years of our perfusion. So normal standard procedure to preserve organs is simple static cold storage. This is dynamic preservation. If you do it from the point of the donor, it is warm preservation all through, and you do that with a blood-based circuit, and that's called normothermic machine perfusion. You could also retrieve the liver, bring it back to your hospital after a period of 4, 5, 6 hours of cold ischemia, and then put it on a machine, and that is called as end ischemic perfusion. That's not full preservation, it's a combination of both. So you are able to perfuse these organs without the problem of having to take the machine out to the donor hospital and bring the machine back. So these are the two slightly different ways of doing it. The latter can be done hypothermic or normothermic. Okay? You've got to take a few things into consideration for these different devices. And again, time will not permit all these, but essentially you've got to know whether they're portable or not portable, what sort of temperature you're doing it, normothermic or subnormothermic, whether your circuit design is closed or open or partly open, because the venous outflow is a free venous outflow. Depends how long you want to perfuse these organs and why you want to perfuse them for long. And then obviously there's a huge cost issue. The cost issue is very significant even for ourselves. So we were lucky to be involved with Oxford along with King's with the first in world trial. This was the best part of 9 or 10 years ago, where 20 livers were perfused. This was a simple safety tolerability study, and it showed that it worked very well. About the same time, we were working on viability parameters, and my colleague Heineck Mergenthal ran most of this. And we call these now the Birmingham criteria. So if a liver satisfied these criteria, we put them as essential criteria and non-essential criteria. It was possible to then consider transplanting these organs. And following this basic work, we got permission to use 5 discarded livers that nobody wanted, put them on the pump, and then transplanted them. At the same time, we also participated in a big randomized study comparing cold perfusion, simple cold preservation with machine perfusion from the donor hospital, called the COPE study. And this showed a significant improvement in terms of reducing early allograft dysfunction, low transaminases after the operation, allowing longer preservation times with graft and patient survival. That was very good. So this is obviously this trial was hugely expensive. It was European consortium funded. And it's something that has been very difficult to repeat. The Americans just completed their 2 trials and published that. On the back of the 5 pilot patients we were allowed to do, we then put together a study on a larger number of rejected livers. So these livers had to be turned down. This was called the VITAL study. This was funded by the Wellcome Trust. And it needed livers that were discarded by all the 7 centers. And you had to have objective, very high-risk criteria. So prolonged warm ischemia, for example, for a DCD liver, or moderate steatosis, or a transaminase of 3,000 or 4,000 in their liver function tests. And these livers were pumped, and we could rescue almost 3 out of 4. So 70% of these livers were rescued. The early survival was very good. The long-term survival in the DBD grafts was very good, but the long-term survival of the DCD grafts was not so good because of a higher incidence of biliary problems. Okay, so 2 things we learned. You can rescue quite a few number of livers that other people don't want. For the DCD livers, simple end ischemic normothermic perfusion is not going to provide your solution to get away from the problem of biliary. Trial work was largely funded. It was nice to have this equipment. You knew it was helping 20, 25, 30% of the liver transplant patients you were doing. How do you then put this into clinical practice? So we spent the best part of 6 to 12 months putting a lot of things in place in terms of training, in terms of getting the funding, in terms of getting this into the system. And my colleague Thamara Pereira, who's now leading the unit, has worked very hard on a project called the Naples Project, which was recently published in the BGS. And the aim here is to use livers that could be put into sick recipients. These could be marginal livers. These could be good livers that you may not be able to use logistically because you have no ITU beds, or 3 offers have come up at the same time, or you want to do a retransplant recipient. And this Naples approach has allowed us to do some very difficult recipients. We've also worked on trying to extend these so-called viability criteria, and now we're accepting a lactate level of up to 2.5, so the lactate clearance, within a period of 6 hours, not 4 hours, which allows more of these livers to be transplanted. We've done most of the work in Birmingham on the warm side of things. There's lots of groups working on the cold side of things, so it's important to put it into perspective. This is cold perfusion of the liver with a double oxygenation of the artery as well as the vein, and this was published as the DOPE trial in the New England Journal of Medicine earlier this year. And this showed in the DCD livers a reduction in biliary problems. So there is a significant future for this. You can also do lots of other things with machine perfusion. I'll just mention a few things. Slow rewarming of organs is beneficial. Normothermic goes you straight to but for slow rewarming, you'd have to use a synthetic oxygen carrier. And we did some basic work with this of cold to warm perfusion. And the Dutch group led by Robert Porter has done the first 11 patients in the world with an oxygen carrier transplanting these livers. Normothermic perfusion or machine perfusion allows you to do lots of things to the liver while it is out. And it has huge potential. And I've just put a few things there. This is mainly a transplanter's perspective. You could improve the fat content of a liver. You could improve the metabolic situation of a liver. For an oncologist, you could take the liver out and instill some chemotherapy drugs. For someone looking at you could do cell therapy through them. We've done, there's enough work that's currently being done, but has not yet been translated in terms of clinical approaches. There are also alternative liver perfusion approaches. Again, just to complete the whole set, normothermic regional perfusion is something you do in DCD donors. So you overcome the big insult of warm ischemia quite early. You convert what is a DCD situation into a near DBD situation. You produce an artificial circulation with an ECMO type circuit. And this is one way the UK is going just now, and we are seeing a significant reduction in biliary problems with this approach. There's another approach which I think we would find almost impossible to adopt in the UK, which is ischemia-free transplantation. And this is a couple of groups in China are doing this, where they perfuse the liver normothermically in the donor and keep it on circuit. So there is no period of ischemia that liver suffers. And it's very attractive, I think, in the setting of the severely steatotic liver. The severely fatty liver, so my severely fatty liver is working beautifully in me. If I put it in the icebox for 10, 12 hours, that's when all the problems start. But if I can prevent it getting cold, then it's something that will keep going even in the recipient. So it's just about tidying. So ischemia-free transplantation would be the holy grail, would be the way to solve it, but I think it's something that will be quite difficult to put in practice. We've learned a lot over the last 10, 12 years. I think participation in clinical trials has helped us hugely. It's also provided lots of recognition for the research team. And these are our two fellows from the Vital study, for example, who both got quite a few awards at both national and international levels. So some simple take-home messages from liver perfusion. Which livers to perfuse, when, and for which recipients. So the standard DBD graft we would put on a machine for logistical lesions, which is multiple offers, late offers, and sometimes to allow a daytime transplant. Say the team have busy done 2 transplants today. Let's put the third liver on the pump, come back in the morning with a new team, and do the third liver in the morning. We also use the viability testing, the readouts you get from the liver while it is on the pump, to be able to tell you whether that liver is working or not working. So it's taken away the problem of primary non-function in the DBD grafts completely. It also allows us to improve utilization of livers. And then for the DCD grafts, NRP or NMP from the time of retrieval, or the use of HOPE is something that is a way forward. The research program has taught us a huge amount as well. Machine perfusion has opened completely new scientific frontiers. It allows us to produce some very high-profile outputs. We were never in the world of Nature Communications, Nature, New England Journal, Lancet, till this kind of work actually happened. And it's very attractive for academic surgical trainees. It's very good to attract good quality trainees into the unit. But we always underestimate how much time and effort is needed to put a 24/7 rota into this. Why do we do it? And what is important? So we've talked a little bit about outcomes before. So we get matrices back from NHS Blood and Transplant about how we perform every 3 months. So we are the red dot in Birmingham. The other 6 dots are the other 6 centers. So it tells us what our overall transplant activity is. It tells us how our activities normalize to our waiting list. It tells us how many offers we accept and how many we refuse. It tells us how good we are at utilizing organs that are being offered. It tells us waiting times. It also tells us our waiting list mortality. So all of this is out there in the public domain, and it's important that this information is you're cognizant of it, you're aware of it, and then any new technology that you introduce does not come at the cost of compromising this any further. So transplantation has been a fantastic 40-year journey of innovation. From simple full-size transplantation to machine perfusion, viability testing, and using of discarded livers, and treating these livers while on the bench. Transplantation is only 1/3 of our work. 2/3 of our work is HPB oncology and benign HPB surgery. So there has to be some knock-on effect of one, and HPB surgery has been the big beneficiary of transplant skills. So I'm going to use two models. One is a model of liver trauma that was clearly put in place very easily just by audit, communication, and pathways. And the next is about pancreatic cancer. And I'll use that because I think a lot of people here are familiar with it. It's completely non-hepatic, and there are transferable skills from transplantation. So staying with trauma first, we were getting sporadic referrals in the 90s. Some patients were operated on. There was nothing systematic at that time. And it became clear that patients who had multiple operations or big operations in the setting of major trauma did badly. So the message went out to all our referring units that please refer early. Please use the CT scan as your diagnostic laparotomy. Don't call us after you've done a laparotomy. Stabilize the patient, get the CT. And then re-audited this conservative approach over the next 7 to 8 years and found that the outcomes were even better. And this is practice that has since stayed. And right now, with a combination of occasional surgery and big help from our interventional radiologists, almost all of hepatic trauma is now managed conservatively. The same thing is translated over to the pediatric world, and almost all our kids now are managed completely conservatively, even if the extent of injury is very significant. We're going to switch across to pancreas cancer, because I think here's where having a big unit that does everything has huge advantages for both sets of patients. So Keith Roberts is very much our Mr. Pancreas just now, and he drives the whole pancreas portfolio along with the rest of us. So what we wanted to do was to try and shorten the pathway. So we've now got agreement, and for the last 7-8 years, almost all patients with a mass, with a double duct sign, without vascular involvement, and jaundice get a Whipple's operation before an ERCP or a stent is placed. Big advantages: shorter time to surgery. There's a survival advantage because you have a fewer rate of patients becoming non-operable. The costs are significantly lower, and most health economists or managers or hospital chief execs are very happy with that kind of information. And we've got a higher potential resection rate. So this is another area that was hugely sensitive. It's not sensitive now, and it will be very sensitive for a place like India. The number of cases you do, volumes. We went through a big period of rationalization in the 90s and the early 2000s, stopping smaller centers doing sporadic pancreaticoduodenectomies. And but the data is quite good. It just shows you that if you are a small center doing single-digit figures, your risk of morbidity and mortality after that procedure is quite significant. You don't have to do too many. If you're doing 30, 40 Whipples, that's considered a moderate-sized unit. The high-volume unit was 60 units, and this very high volume was 100 plus. But even if you were a moderate-sized unit doing 30 to 40 Whipples a year, your outcomes were very close to what was seen with the very high volume units doing 100 plus Whipples a year. But the numbers say it all in terms of what your outcomes are. We then took on a few more sensitive issues: individual surgical outcomes and individual surgeon pancreatic fistula rates. We've got fixed definitions now for clinically relevant and clinically non-relevant pancreatic fistulae. And we lumped together the experienced surgeons versus newly appointed consultants and compared expected pancreatic fistula rates compared to their observed rates. And individual surgeon experience does make a difference in the medium to long term. And what's even interesting is that it continues to be there forever and ever. You then have to risk adjust this. And these are two curves of two surgeons within the team, obviously both not identified, with 2 very different fistula rates. And you can see that the experienced surgeon continues to improve even as he goes 10, 15, 20 years into his practice. 1 or 2 other areas, non-oncology treatment, so simple enzyme supplementation. So we worked with the group in Hanover with Harald Schrem, where they observed that patients who received exocrine supplements did far better following benign Whipples compared to those who didn't. And we found the same effect in the cancer patients. Now, whether that's immunological, whether that's nutritional, is still yet to be uncovered. And then this is the area that is most interesting for us just now. We know for every 10 patients that are referred to us with a tumor, pancreatic head tumor, that we can resect 1 or 2, maybe 2 out of them. Half of them will have distant metastasis, so they're never going to be candidates for transplant, for resection. But there's a group of 30% that have disease that is either borderline resectable or locally advanced. And with the advent of neoadjuvant chemotherapy and surgical skills, you can eventually get to a point where you can offer resection to far more patients. So this is venous implantation with a cadaver vein graft with implantation of the splenic vein and the supramesenteric vein. This is a temporary portocaval shunt using some iliac vein from the fridge from our transplant program. So for completely occluded portal veins, and even reconstruction of some of the smaller veins after these diseases have been downstage. So we heard a nice presentation earlier on talking about downstaging, identifying the beta biology disease, and then being aggressive with the beta biology disease. The same thing at an arterial level is a bit more controversial. So this is periadventitial arterial dissection after neoadjuvant chemotherapy. This is a replaced artery going through the head of the pancreas that has been resected and anastomosed. And this is a one-off situation where a splenic artery has been swung across to reperfuse the liver. It's important that when you've got good data, large amount of patients, to be able to look forward. So if one looks at how the evolution of pancreatic cancer, forget the other two groups, because the other 2 groups are pretty well served, periampullary and cholangios. You can see that the numbers have gone up over the 80s and the 90s. The age of patients that we're operating has gone up. The pathology shows more and more patients with pure ductal adenocarcinoma. Means we are doing more patients, but more difficult patients, not just the straightforward, simple periampullary Whipples. And the proportion of vein resections continues to go up. So for our PDAC patients, 1 in 3 is now getting a vein resection. If one extrapolates that forward, we're going to be operating on more patients, more older patients, more difficult patients, okay? And half of them will require vein resections after they're downstage. So it's suddenly become a completely different operation to your standard Whipples operation. And that creates its own problems. There are 27 centers in the UK doing Whipples, but probably only 5 centers doing this level of, so the care is going to be slightly different across. We can't talk about pancreatic cancer without talking about training opportunities, and I don't know if there are many trainees here or surgeons here. Keith asked me just to plug this. He's running an audit that is prospective, that is worldwide, that already has 70 centers contributing to it. It's called Paranoia. It's the ability to put the same pancreas anastomosis data that can be either identified or non-identified exactly as you want. And if you just visit the website, it's very easy to access. That's Rupali who's running that. One of the big joys of working in Birmingham has been the ability to work with huge numbers of fellows. We're currently 900 plus surgical fellows that have come through. This doesn't include the medical fellows, and it doesn't include the short-term visitors. And I think it's nice to see that the largest number of people have come from this part of the world. It's been a huge number of surgeons that have worked with the team. I was very lucky to be amongst the early group, so the second generation after the first generation, that was Paul, John Buckles, and David Mayer. But we've right now got a team of 11 surgeons working across 2 hospitals. So where are we now after almost 6,200 transplants, almost 5,000 liver resections, almost 2,500 Whipples, and just over 100 bowel transplants? It's a recognized and a desired specialty. Unfortunately, we've got different job plans now because it's not possible for one surgeon to be doing the whole breadth of HPB and transplantation. We're still privileged to be a destination for trainees both from the UK as well as from overseas. And it outlines very much the working as a team at its best level. And this big workload allows a huge amount of clinical research, basic research, as well as translational research. And all those three aspects are hugely important. Anything that works well has got problems. And it just shows that we've got huge pressures now with resource limitations. COVID has made that worse. Our challenges now remain how to transfer the skill set to the next generation, given that they're all working in slightly separate silos compared to us who worked across the board. I think finding the next generation of committed young surgeons is not easy because it's no longer a sexy specialty. It is considered less than ideal. I think robotics and laparoscopic work is attracting huge numbers of high quality trainees. And then we've got a problem now of varying national delivery of the more complex HPB surgery, the vascular dissections, etc. And then there are very few consultant jobs that are comprehensive, that allow surgeons to do everything. Lots of people to thank, big contributors, and I'm very grateful to Thamara, to Heineck, and to Keith for some of the more recent data that they've provided. Once again, I'd like to thank the organizers for the opportunity to be part of what I've just learned is a hugely prestigious event. Thank you.
Thank you, Professor Darius, for this enlightening talk. May I request our President, Dr. Bhalla, to kindly honor the guest